Good morning. Happy Thursday, everybody.
Thursday.
It's bright and early here. It's funny tracking the seasons on VMR. I remember a time when we were doing Thursday VMR at the exact same time and the sun was up. But no, we're heading towards winter, slowly but surely. Um, yeah, but I'm still just as excited to hang out with you all today. I will first introduce the people who are making this possible. The first is one of our newest Academy members, Masa, who is scribing. Masa, do you want to unmute and say hello?
Hey everyone, I'm Masa and I'm gonna be scribing today.
Masa is super, super excited to have you get your second rep this week. I see Khashar is doing too. I thought I saw his video, but I might have lost it now. Khashar is doing teaching points today. You want to unmute and say hi? I'm seeing the journey to the mute button or nystagmus, one of the two things. Which one is it, Khashar? Are you looking for the mute button or are you um
Hi everyone. Sorry, my connection got reset there. I couldn't hear. I'm Khashar, medical student from Iran. I'll be doing the teaching points today.
Yeah, the scribing teaching points are coming to you from the Middle East and Dubai and Iran. This is we're gonna have to go a little bit further east to tell you who the case discussant is, but it's kind of silly to introduce you to Anmol. Anmol is now a pillar of CP solvers. This is her fourth, maybe the third or fourth discussion. I can't quite remember. She's doing another one in the future. But for those of you who don't know Anmol, you'll probably become more and more familiar with her as she's become one of our leaders of the case review committee, which is not a small feat. It's essentially everything that you're seeing happen here and we'll see happen here is in large part because of her efforts. She's applying this year to the match, and oh, so excited to use this as a way to celebrate what she's accomplished, but also to help prepare for her journey going forward, especially next year. So, Anmol, I'll hand the mic to you to say hi, and then we'll introduce our case presenter.
Such kind words, Dr. Rabi. Thank you. Thank you very much. Thank you very much for everything. And a very good morning, good afternoon, and good evening to everyone. It's evening where I am right now. I'm in India. So it's a virtual evening report. And I'm very, very excited for the case discussion today. And I hope that the knowledge we all share may help me in the future when I actually come across a patient like that. So I'm very happy and very, very honored to share this space with you all. Thank you so much.
The pleasure is all ours. But now we get to introduce our case presenter. Bralis, do you want to say hi?
Hey everyone. My name is Barth. I'm a PGY2 internal medicine resident at Virginia Commonwealth University. If you ever heard of Richmond, Virginia, highly recommend you all visit. But yeah, that's a little bit about me. Excited to
Yeah.
get this case going.
First time I ever came to the US was in geez, sophomore year of high school, and my brother was living in and is still living in Virginia, but now he's in Blacksburg. So I got
Oh,
to see Richmond, Virginia. I've actually been there before. It's a really, really cool town. Are you
yeah.
originally
So you
from there, or where's home for you?
So I'm from Northern Virginia, a
Gotcha.
small kind of place called Ashburn. It's a shoot off of Washington, D.C.
Nice.
Um, so this is 2 hours from there. I've been here for quite a while, so
Yeah.
great
How's resident
place.
how's residency going?
Residency, intern year was tough, but a lot of growing. PGY2 kind of similarly, but in a different fashion. So you
Easy.
just kind of take it day by day, right? The weeks
Yeah.
are short, but the year or the what is it? The saying, the days are long, but the years are short.
Amazing. I think the best part of the saying is that as a resident, you have an excuse to forget all the sayings because your mind is too busy and preoccupied doing all the things. What do you like?
Exactly, involved in the clinical work.
Exactly. What do you like to do outside of medicine?
I am a big soccer player. I
Ooh.
love playing soccer. I love watching soccer. Yeah, I've seen some of your past videos. The Manchester United jersey. I
Yes,
hope it's somewhere around there.
it is.
Um, so yeah, I just really like just trying to stay active, honestly, outside of the hospital.
Love it. I love it. What position do you play?
Center mid.
Oh,
Yeah.
salute
Yeah.
to you.
A
Most
lot of
important.
running, a lot of running.
Yes, yes. I used to as a kid. I went for the glory as a youngster, wanted to play striker all the time, but I think with maturity, I've dropped back to center mid as well. That's just
Yeah.
so much fun
Yeah,
to
I
play.
definitely used to play there as well, but after 0 goals in a season, my coach just like, you gotta move back.
Well, I think that no matter what happens today, I think we'll have a ton of fun, and I think you'll come out victorious, no doubt about that.
Absolutely.
I'm curious, how have you interfaced with CP solvers as a resident? Because I know that's really, really tough. How have you come to know about the space, and how did you end up here today?
Yeah, so I have a mentor, Dr. Patrick Fadden, who kind of
Yeah,
introduced me to CP solvers and also the Human DX project.
awesome.
So when I was a medical student, I actually submitted a case to Human DX, and
Nice.
then I came across this case, and he suggested that I submit it to CPS solvers, and now we're here.
Here we are. Amazing. Yeah, we miss him. Patrick used to be a regular on VMR during the pandemic when I think everything was
Yeah.
shut down, and I think I imagine his clinical duties now are like literally interfering with being able to be here. But we have very, very fond memories of him, and excited to see him and his mentorship live on in you today. So thank you for being here. We're very excited for your case, and we can go ahead and share the screen, which we did not practice at all behind the scenes, and we'll rock and roll.
Absolutely. So let's get this started. So I'll go with aliquot 1. 42-year-old male who presents with 2 weeks of chest pain. And I'll give you a little bit more characterizing factors of the chest pain. So he characterized it as constant, substernal, and radiating to the right shoulder. His pain acutely worsened over the last day, along with the development of new onset shortness of breath. Interestingly, his chest pain improved with yard work, but he denied any worsening with deep breaths, cough, positional changes, or exertion. Some pertinent review of negative systems questions include no diaphoresis, no GI symptoms, including nausea, vomiting, diarrhea, or any systemic symptoms, including fever or chills. And I'll stop there.
Super helpful. Anmol, I'm curious if you were to sort of do the mental checklist of some of the diagnoses you don't want to miss when somebody has chest pain. What is that short list for you?
Yeah. So I think whenever we see a chief complaint in general, it's important to first rule out the emergency causes. This has a picture kind of a subacute, but the chest pain has worsened. So it makes us think about what are the emergency causes, and we have that 4+2+2 framework, which we can use to rule those out. So 4 causes are cardiac. I will definitely want to rule out acute coronary syndrome. Then I would want to rule out Takotsubo cardiomyopathy, then cardiac tamponade, and aortic dissection. These will be the 4 cardiac causes. And then we have the 2 pulmonary causes, which are pulmonary embolism and pneumothorax. And then the 2 esophageal causes, that are esophageal impaction and esophageal perforation. So these will be the main causes which we want to look out for when a patient comes with the chief complaint of chest pain. And in case if it's accompanied with shortness of breath, then also I recall from one of the VMRs you taught us that the shortness of breath is also varies according to the presentation. How is the patient looking like? Is he tachypnic, or like, or how is the patient presenting? Is the shortness of breath present on rest, or how is it? So it changes our differentials. And so I think the main causes which we want to rule out, the emergency causes, will be the 4+2+2, and we can go for chest X-ray, EKG, and the cardiac biomarkers, maybe to rule those things out. And that's what I think about the chest pain right now.
I think that's superb. Not only have you laid out all the scary possibilities, I think your plan to try to tease them out going forward is very, very powerful. It's interesting to think that this has been going on for 2 weeks, because the longer that it goes on without evolving into something else, it makes it such that it will probably never evolve. And so if you just change this, instead of saying 2 weeks, you said 2 years, then you would probably say, well, this person is probably just going to have chest pain for the rest of their life. if they've had chest pain for 2 years and it hasn't gotten better, but it hasn't gotten worse. And so I think what we're really listening to when somebody has a pain problem is we're using the pain problem to help us figure out if they're going to have a functional problem. The whole point of pain is to protect you from dysfunction. And so for somebody just has pain without dysfunction, then the problem's probably with the nerves rather than the system, right? But it's interesting that this patient's dysfunction has now begun. And that dysfunction is really in the fact that the thorax is failing because the patient is feeling shortness of breath. And so it's a really interesting question to say, what kinds of sinister causes of chest pain will result in dysfunction not on day 1 or day 2 or day 3 or day 4, but on day 14? And I think that's an interesting space to try to analyze this problem. We have to remain focused and not miss an unusual presentation of something that is common. But I think in the back of our minds, we have to answer, why did dysfunction take so long to set in? And the most common answer to that in real life is coping mechanisms. Patients hold on to their pain for longer than they should have, ideally, from our perspective, because of access to care, healthcare literacy, distance from the hospital, fears or concerns about what they have, hoping it'll go away. That's the most common realistic answer. The pathophysiological answer to that is a high reserve, meaning that you are having an emergency, but you're having an emergency in a space that can hold that emergency. So I'll just give you one small example. You have pericarditis, but you don't have a pericardial effusion on day 1 or day 2 or day 3 or day 4. And on day 5, you get a little effusion. Day 6, you get a bigger effusion. Day 7, you get a larger one. And then finally on day 12, you get tamponade physiology, and then you become short of breath. High reserve. So let's proceed by getting more and more information and ultimately follow the path that you outline. Chest pain, have to rule out the emergencies. But the unique question that we'll try to answer is, why did dysfunction set in on day 14? What about this? And to do that, in real life, we would probably learn about the patient and his family, social circumstances. I understand that we might not learn that in this context for HIPAA purposes and other purposes, but then also analyze, is he having disease in a space where the problem can be contained for a small period of time? So let's see where that goes. We'll hand the mic back to you to get a little bit more information, Bart.
Yeah, so in terms of histories, past medical history, notable for HIV, most recent CD4 count was 447. He also had a history of toxoplasmosis, complicated by CNS involvement in epilepsy, currently on anti-epileptics, which I'll get to. Acquired factor V deficiency, and cardiac arrest with anoxic infarction of the bilateral thalami. In terms of surgical history, he's had a percutaneous gastrostomy placement. Family history was only relevant for a mother with type 2 diabetes. And health-related behaviors, he vapes daily, smokes marijuana daily, and drinks a pint of hard liquor once per month. In terms of meds and allergies, he's on dapagliflozin, dolutegravir, rilpivirine, lacosamide, levetiracetam, levothyroxine, and metformin, and he has no allergies. And would you like me to proceed to the physical exam also?
Honestly, whatever you had planned, I know you
Okay.
were very thoughtful about how you divided things up. So
Yeah.
what do you like?
So I can give the vitals and physical exam as well. In terms of vital signs, he was afebrile, temperature of 98.2 Fahrenheit, heart rate at 58, blood pressure 104/79, and a respiratory rate of 19. For physical exam, the pertinent I'll give first, cardiovascular exam, he was bradycardic, regular rate though, no murmurs, rubs, or gallops, normal S1 and S2, no peripheral edema, and no JVP. Pulmonary exam was completely benign, clear to auscultation bilaterally. And just for completion, he was not in acute distress. HENT was normal, and he had no abdominal tenderness and normal bowel sounds. I'll stop there.
Interesting, interesting. Anmol, what are you making of the medical history here?
The medical history makes me realize that the patient is immunocompromised. So definitely the infections which can occur in an immunocompromised patient are something to be looked out for. And he has a cardiac history already, being a 42-year-old male. So that's very interesting as well. That the cardiac arrest, like what was the cause, why it was, that is something which I'm thinking about, that what could have caused that cardiac arrest. And then I think the history of toxoplasmosis is can be understood because of the immunocompromised state of the patient. In HIV patient, toxoplasma is definitely one of the possibilities. And other than that, I think if then there was also a history of vaping as well. So that can also contribute to many of the shortness of breath symptoms. I believe when we see a patient in real life, there is not really one particular diagnosis. There are many multiple factors contributing. So definitely vaping could the regular vaping history. And that's what I'm thinking about the past medical history. But yeah, what do you think about that?
Yeah, no, I completely agree. I think that's a very shrewd analysis. I have nothing to add to it. What did you analyze with the exam?
The exam was definitely very important to analyze, since we have to understand if the patient is hemodynamically stable or not. So the main finding which was there is the low heart rate, the bradycardia. Other than that, the whole exam is normal, which is again very interesting because the patient said he's experiencing shortness of breath. So basically right now, right sitting right there, when we are examining the patient is not short of breath. So that means that we can that this could be like a developing problem, not just an acute problem. That's what I'm thinking. And I think about the low heart rate. I have to maybe think about that. What could cause the low heart rate in this patient? I cannot really make anything out of the physical examination except the fact that the patient does not really need any oxygen right now, or maybe what was the saturation for the patient?
It was normal.
Okay.
Yeah.
So
Yeah. Your facial expressions are so powerful here, I think, Anmol. I say that because if you were to be honest right now, of course, this is VMR. We all know that, but this is practice for real life. How worried are you about this patient? Would you say that the chances of finding a scary diagnosis are low, a medium, or high? What do you think?
if I talk about emergency, currently I don't see any emergency signs, but the imaging might reveal something else. But
Yeah.
currently the patient is hemodynamically stable and
Yeah, what if I give you a number? I'll tell you that about 85% of patients who come into my emergency room with chest pain get discharged. So do you think there's anything unique about this person that would make them be part of the 15% who get admitted? I don't. Nothing yet. There's nothing here. And I think that's important to be honest about. And the reason it's important to be honest about it, because what you said is so true, is the possibility of a sneaky, sinister emergency in patients with chest pain means that a history and a physical is not sufficient to rule out scary causes. So that's learning point number one. The patient here, while he has an interesting background medical history, has a subacute presentation of chest pain without any signs of dysfunction on exam. There's no tachypnea, hypoxia, pulmonary edema, or elevated JVP. His lungs seems to be working fine. His heart seems to be working fine. And this is after giving him 2 whole weeks to declare himself in a more sinister way. So you can, I think, authentically say that the pre-test probability of a benign cause of this discomfort is very high at this juncture. But the learning point is that in patients with chest pain, the ability of the H&P to be able to say this definitively is limited. And that's why we do a workup for all patients with chest pain. Now, the extent of the workup depends on how worried you are. If you're very worried based on the history and physical, you will often get serial EKGs, serial troponins, and an extensive workup to be able to reassure yourself. And if any of those are positive, you're done. If the patient has a low-risk story and exam, then the workup of an EKG, a chest X-ray, basic blood work, and rule-out tests. The rule-out tests here would be a troponin for cardiac ischemia and a D-dimer for pulmonary embolism and aortic disease. And so I think you would say, let me get those basic labs, that EKG, the D-dimer, the troponin, and the X-ray. And if they're negative, I think that you can say, hey, you've had this for 2 weeks. I don't see any problems now. Let's keep an eye on it, but you can go home. Now, as a general rule, if we're asking where can this disease hide, because whatever, if this person turns out to have a sinister cause, it is hiding very, very well. And the most common place that a disease in the chest hides very well is in those microscopic arteries in the heart, very, very small. But the mediastinum is a notorious place to hide disease. I say that because his lungs are clear and he has no signs of pleural disease. So if you imagine the chest as a whole, you can almost rule out his whole right lung based on the exam and almost rule out his whole left lung on the exam. And then you're left with everything in the middle. And everything in the middle is the cardiovascular system and the mediastinum. And so far, the cardiovascular system does not seem to have a prominent signature. So what's left? A subclinical cardiovascular process like a large effusion, not yet sufficient to cause pericardial hypertension, but more and more so, if he has something, I suspect it'll be hidden in that sneaky space in the mediastinum. That's one place where you can literally hide everything, sandwiched between the heart and the lungs, and can have some pretty serious problems. So I think, as you said, the probability is low, but this case, I think, illustrates the idea that an H&P is not sufficient to rule out some scary things and cannot reach far enough in the body to exclude mediastinal issues and coronary artery issues, which is why we get those tests that we just talked about. So why don't we head and get that next round of data?
Yeah, so very interesting. Labs, I'll start with. CBC, white blood cell count was 11.3 with a diff of neutrophils of 86.1%, lymphocytes of 10.7%, monocytes of 3.2%, and absolute and relative eosinophils of 0%. His hemoglobin was 12.7 and his platelets were 314. For BMP, sodium was 130, potassium was 4.5, chloride was 98. He had a bicarb of 18, a BUN of 21, and a creatinine of 2.05 with a baseline creatinine of 0.7 to 0.9 over the last year. Glucose was 125. His magnesium was normal at 2. Lipid panel, hepatic function panel, and A1C were all within normal limits. Immediately, we also got a troponin, as mentioned, which was 7.75, a CKMB, which was 43.3, a BNP of 2,857, a TSH of 4.04, and an ESR of 120, and a CRP greater than 31.7. Now, the EKG was normal rate 78 beats per minute, regular rhythm, left axis deviation, low voltage QRS, and ST elevations in V1 through V4, lead 2, lead 3, and AVF. As you can imagine, this patient was taken for a left heart cath immediately, which showed right dominant circulation, but no critical CAD. And I'll stop there before giving some more labs.
Who expected that with that data? I mean, that's just unbelievable. It goes to show you how well a patient can appear with some very serious things hiding inside. Just to get clarification, Roth, maybe I can ask you. You said the troponin was 7. I heard the BNP was very elevated at 2,000. I just missed the troponin. I thought it was 7. I'm curious what your units are, because is this a high sensitivity troponin, or so? What would be normal?
So I guess normal would be less than 0.03.
0.03. Okay. Oh, this is great. And this is a
very elevated.
Okay, gotcha. Okay. Yeah. All right. So Anmol, maybe we can sort of summarize the progress that you made. I think maybe the first thing to wonder is, where do you think the problem is now?
I definitely think that the problem is more localized towards the heart. And if I talk, first of all, about the troponin and CKMB, there's one very interesting pearl which I was going through some days back. When we talk about these biomarkers, troponin is the marker, correct me if I'm wrong, troponin is the marker which stays elevated even after 7 to 10 days of the myocardial injury. CKMB, it just gets down within 24 to 48 hours. So that was just a side interesting pearl, that if we have to test for reinfarction in 2 or 3 days, we go for CKMB. And what I talk about troponin can be elevated in myocardial injury. So it could be ischemia as well, and it could be inflammation of myocardium. So it can be elevated in myocarditis as well. And so that was what I'm thinking. And the high BNP makes me more focused towards the heart failure kind of a pathology if we just go and see towards the labs. Then after that, we see that in the EKG, the low voltage QRS. The low voltage QRS can be in numerous conditions. For example, the first one being the pericardial effusion causing the cardiac tamponade-like pathology could be one of the causes. And then in obese patients as well, we can see low voltage QRS. So this definitely seems like the pericardial effusion, which is growing because of some pathology, a pericardial effusion which is growing and getting towards the cardiac tamponade-like pathology, but not enough to cause the elevated JVP. And the diffuse ST elevations make me think about acute pericarditis too. This currently is looking like a picture of maybe myopericarditis, for which we don't know the reason yet, the cause of it yet, but it looks like a picture of myopericarditis with high inflammatory markers. The ESR, the CRP is high as well. And I think that's what I am thinking. In the echo as well, we see the ejection fraction is low. So it just makes us more concerned about something that is maybe compressing the heart from outside, which is leading to less ejection fraction. So that could be the cause. And that's what I'm maybe thinking. And but I'm not able to reason out the bradycardia. If I'm sure it must be related. All the things must be related, but currently I'm not able to reason that out. But what if I talk about the problem representation, then I would say that it's a middle-aged male who presented with subacute chest pain with evidence of basically cardiac pathology, mostly in the labs. I will frame the problem representation in the next aliquot, but what do you think about it?
I think your localization skills were excellent here. And I think before you got the echocardiogram, which I actually honestly didn't hear. I don't know if we got that as a bonus gift. But I think you probably would have this data by the time that you have the left heart cath in most instances. But we were like, where's the problem? And then you have a positive troponin. And a positive troponin, as you said, tells you there's myocardial injury. And myocardial injury is either as a result of ischemia or direct myocardial injury from myocarditis or Takotsubo's. And when you cath the patient and you see there is no evidence for them to have increased demand, neither of those hypotheses are plausible. You start to get closer and closer and closer to either that the patient had a missed ischemic event, which seems unlikely based on the story, or the patient has myocarditis or has Takotsubo's. Takotsubo's would be pretty unusual in this age range, and so I think that it's very fair to say that a troponin elevation without a coronary vascular correlate in a patient who's inflamed should give you the operating diagnosis of myocarditis. And I think you started to pivot towards pericarditis based on the EKG. And I think that's a very wise thing to do because you have low voltages and you have diffuse ST elevations. So the differential diagnosis for low voltages is really what you said. Are the voltages actually high or normal, but there's something in the way? And the things that could be in the way are a large pericardial effusion, big lungs from COPD or adiposity, or are they low because they're diseased? And they could be diseased because they were infarcted and gone. And so when you have low voltages in this context, it's attention to figure out, is it just because of the myopericarditis and the loss of myocardial tissue? Or is it because there's something in the way? The ST elevations are interesting. In pericarditis, you expect diffuse ST elevations in all the leads, along with ST depression in AVR. And so here, the lack of ST elevations in V5, V6, lead 1 and lead 2, and the lack of ST depressions in AVR, along with the lack of changes in the PR interval, should give you pause and say, wait, yep, low voltages and ST elevations should make me think of pericarditis with an effusion, but they're not diffuse in every lead, and there's no ST depression in AVR. Before you get the echocardiogram, there's one other big reason why the pericarditis hypothesis is weakened a little bit. It's because most patients with pericarditis and pericardial effusion have a low BNP. The reason the BNP is low in patients with pericardial disease has to go back to understanding the pathophysiology of BNP. BNP is secreted as a result of atrial stretch from volume on the inside. And so when you have a large pericardial effusion that compresses the atria, they're not stretched, so the BNP tends to be underwhelming. So I would say the positive troponin, in the absence of coronary ischemia and the absence of evidence for a reasonable cause for increased myocardial demand, has myocarditis as an operating hypothesis reinforced by the inflammatory markers. Myocarditis can be accompanied by pericarditis, but ultimately the EKG, while suggestive of it, is not fully consistent with it given the absence of ST elevations in V5 and V6, most importantly with the absence of ST depressions in AVR. But more definitively, the QRS is not explained by the echo, as there is no pericardial effusion on that echo. And so I think now you become really worried about the possibility that this person has myocarditis. You would be able to be more confident about that possibility if the patient were to develop you would be more confident about that possibility if you get an MRI, which has characteristic features of myocarditis. But I'm curious what thoughts or questions you have about that analysis.
Yes, I think one more point which we can say is that if the echo is showing reduced ejection fraction, and if the previous echo was normal, and if it's a new onset heart failure, that also emphasizes that the patient could have myocarditis. And that's what I'm thinking. And I love the hypothesis of the that we have the ST elevations only in the anterior and the inferior leads, and about the low voltage QRS, that if there is something in between the leads and the heart, is it if it's fat in the form of obesity, or if it is effusion, the fluid in form of effusion. So I love the concept. And one more thing we have to touch about is the creatinine. So maybe creatinine, if the if it is 3 months prior, if the baseline was normal, then it could also be the acute kidney injury secondary to the low output. So that's what I'm thinking.
Yeah, I agree with you. I think whenever you have AKI in the context of heart failure, you're wondering, is it a plumbing issue or is there an underlying disease that's causing both entities? I think in the situation of presumed myocarditis, you know there's an inflammatory insult in the heart. And if you take all comers, in all comers, the most common cause of inflammation in the heart is idiopathic and unknown. You don't really know why. Of course, we're not going to say that from the beginning. And so the question is, what pathway do you take to try to figure out what the cause of inflammation is? And the first thing you can do is to review the list of medications for any causes of drugs or recent vaccinations. That's easy. So if you looked at his med list, Anmol, and you saw that he was on clozapine or immunotherapy, you would really worry that he has drug-induced myocarditis. But I don't see any offending drugs. In the era of vaccinations, unfortunately, there's a measurable but very, very low risk of vaccine-induced myocardial injury, and that's not in the space here. So drugs is the most important thing to do first. After drugs, we worry about the possibility of infectious causes of myocarditis, and then ultimately think about autoimmune-mediated causes of myocarditis. So the journey is drugs, infection, autoimmune, and then finally idiopathic. You noticed I skipped malignancy. Malignancy can cause myocarditis often in the form of eosinophilic myocarditis from hypereosinophilic syndrome. That is still possible because patients with eosinophilic myocarditis may not have peripheral eosinophilia, but only have myocardial infiltration alone, which Mark presented to us a while ago. But those are hypotheses further down the line. I think the question is now, could this patient have infectious myocarditis? But I think, well, let's leave it at there. We spent a lot of time on this aliquot. I think the progress we can make is to worry about myocarditis and let that journey unfold of trying to get to the bottom. All right, you have us very intrigued by us. Take it away.
Yeah, very interesting hearing the discussion. So the echo, just to reiterate, EF of 25 to 30%, RV systolic function that was moderate to severely reduced. And like you all mentioned, the infectious workup, Toxocara antibody was negative, strongyloides antibody was negative, Quant Gold TB was negative, Lyme antibody was negative, Neisseria, gonorrhea, and chlamydia were both negative. Blood cultures obtained for 5 days was negative. And then the patient actually went for a right heart cath with low filling pressures, reduced cardiac output, and an elevated systemic vascular resistance, which overall improved with IV fluids and dobutamine. And then a cardiac MRI was obtained with notable extensive epicardial and mid-myocardial enhancement, decreased ventricular function. LVEF was 30% and right ventricular ejection fraction was 16%. And then I'll stop there.
Awesome, Bart. Just to help us with the time management, how many more aliquots do you have until you would
Just
tell us?
one more.
So there's one more round of data, and then you'll tell us the answer, or the answer
Yeah.
is
I
okay.
can give you the biopsy results.
No, it's okay. It's okay. It's all
Yeah,
good.
okay.
Yeah. So just to help pace. So we have one more round of data, and then you'll give us the ultimate diagnosis. Is that right? Awesome. Okay. Super helpful. Yeah, we have time then. So Anmol, what do you think?
That's very, very interesting. So if we talk about the infectious causes, so most of them, they are ruled out. And if I talk about the elevated systemic vascular resistance and reduced cardiac output, that is just making me think about the physiology. I'm just trying to understand that the systemic vascular resistance when it so maybe basically it's just painting the picture of a cardiogenic shock in this way, and which gets improved with IV fluids and dobutamine. Then the cardiac MRI, which showed extensive pericardial and mid-myocardial enhancement. I'm not sure what that means. The enhancement and decreased ventricular function. And the right ventricular ejection fraction is less, 16%. So maybe something with the lungs, I'm not sure. Or maybe something is compressing from outside, which is reducing the ejection fraction. So I have to, I don't know what to make of all these things. And I would definitely want that if you analyze the situation and ask me some questions, maybe then I can answer it better.
Oh, I mean, this is so when you're an intern next year, you'll be watching at the sidelines as the cardiologist manage this case. You're just going to be learning. There's no expectation for you to know anything in this circumstance, but your analysis of the coronary right heart cath is excellent. He has an elevated systemic vascular resistance. That means that if he's hypotensive, the cause is not the vessels, which must mean the cause is the heart, right? If you have hypotension with clamped vessels, it's not sepsis. It's not, it could be hypovolemia, but it's not sepsis. So I would say that coronary angiogram probably means the patient has been, the right heart cath, the patient has been well diuresed, but still has a low cardiac output. So you probably have to keep the patient on diuretics to make sure they don't get hypotensive. And the cardiac MRI, I'm no expert in reading cardiac MRI, but the read is evocative of what you were suspicious of, which is that this patient has myopericarditis. And I think you now have proven that diagnosis that the patient has myopericarditis. So, Anmol, why were you not able to say much? Because I think that your hypotheses have just been more and more reinforced. And you haven't pushed the case any further, but you've developed more confidence that you did not miss a myocardial infarction. And because the MRI would show you evidence of a delayed MI or some sort of consequence. So I think you now are like, okay, no, I'm definitely in myopericarditis. But the reason that this patient is has the ST elevations and whatnot, and the heart failure syndrome is probably the myocardial component, because there is no effusion to explain the pericardial component. So we're on the same journey of myocarditis and what causes it. So we've ruled out drugs and vaccines. We're in the world of infection. And then if we don't find anything on infection, we'll go to autoimmune. And the autoimmune category includes two things: giant cell myocarditis and eosinophilic myocarditis. So Anmol, at this juncture, I think the key question for us is, this is not knowledge that anyone should really know off the top of their head, but let's practice. So what infections do you associate with myocarditis?
I think Chagas disease is one of the the possibilities, but it has some other manifestations as well.
Yeah. Yeah.
Yeah, that is one of the possibility. And um, Lyme disease can also cause that. And I think, yeah, I'm not sure about all the infections.
Yeah. There's actually a very hard, the literature here is very weak, because if you look, you'll find all sorts of viruses that do it. The question is, which infections are known to do it reliably? And there are 4 of them. There are 2 C's and 2 T's. COVID, but not COVID in itself, post-COVID multi-system inflammatory disease, MISA. And in this patient, checking a COVID or a COVID antibody would probably be very helpful, because 70% get it while their PCR is positive, but 30% get it as a delayed manifestation of post-COVID. The other one, so COVID antibodies here and a COVID PCR. The other one is Coxsackie, hand, foot, and mouth disease. So I would get Coxsackie serologies and a PCR, and I would look very closely in the back of his throat, because it's so easy to not look in somebody's back of the throat when they don't have throat pain. But if you see 1 or 2 vesicles back there, you'd think Coxsackie. Those are the 2 C's. The T's are almost always in immunocompromised patients, and the T's are Toxocara, which we have the antibodies negative, trypanosomiasis, Chagas disease, and toxoplasmosis. Toxoplasmosis-related myocarditis is very well described in advanced immunocompromised patients. This patient isn't quite the classic patient because he's relatively immunocompetent, but we know he's had this infection in his brain. And so it could be easily invoked to explain myocarditis right now. As you said, there are many other infections that do this, but with not reliable frequency. You mentioned Lyme, that's on the list, but it usually actually causes conduction system disease more so than it causes myocarditis. But you already have been thinking bradycardia, bradycardia, bradycardia. Could that bradycardia be a clue that the patient has Lyme? Myocarditis from Lyme would be rare, but it's been described. So I think what would we do in this situation? I think we would probably get COVID antibodies, do a good exam for Coxsackie, get Lyme serology, and then I think do as much serological testing as we can for Chagas disease and for toxoplasmosis. But ultimately, the real path for almost all these patients with myocarditis is to wonder if they need a myocardial biopsy. That is a very tough decision to make, whether or not to biopsy somebody. And the reason it's tough, Anmol, is because the vast majority of patients have idiopathic myocarditis and the biopsy is not productive. And so since it's a risky thing, and in many instances it's not productive, cardiologists have to be very thoughtful about who they expose the risk to. And one patient population that they're more and more comfortable exposing the risk to is patients with fulminant myocarditis who develop it very quickly. And I think that's where his time course and his degree of troponin elevation and his BNP raise alarm that he may fall into that category. So what would I suggest? I think remember that your serological workup for myocarditis, the C's and the T's, is very rarely productive. And the real decision is, do you do a biopsy or not? Another tense decision, Anmol, is whether you empirically put the patient on steroids for the deadly diseases of giant cell myocarditis and eosinophilic myocarditis. If you're going ahead and going to do the biopsy, I would suggest not doing it to not reduce your biopsy yield. But if you're not going to do the biopsy, it becomes a tense decision about that possibility or not, which we'll leave for another time. All right, I could talk about this forever, but I'll pass the mic back to you, Bharat, to tell us what you all did.
Sure. Sounds good. Yeah, so last aliquot. So we did get the cardiac biopsy, which showed myocardial infiltration by lymphoplasmacytic cells. multinucleated giant cells, eosinophils, and no necrosis. And so luckily we were able to capture a region where there was eosinophils and the diagnosis was made for eosinophilic myocarditis in this patient.
Wow, awesome. Thank you so much, Bharat, for that. Really, really interesting. Anmol, what do you think?
I have actually learned a lot, and there were many, many great teaching points in this case. I was just reading about the increased eosinophils. So there also we had that schema that eosinophils can infiltrate three main organs, like they can go for skin, GIT, and lungs. And in serious cases, they can infiltrate heart and brain as well. I'm just thinking about that. And I have to read about this diagnosis because I'm not sure that if eosinophilic myocarditis, how does it relate to increased eosinophils in the blood? Read and correlate all of that. But I learned a lot, and how I actually concise it will be that it's a new onset heart failure which made us think about the myocarditis, and then ultimately the diagnosis was made upon cardiac biopsy which showed eosinophils. But I learned a lot. Thank you so much for bringing the case, and thank you for the amazing discussion.
Anmol, I thought your analysis was so authentic the whole time. You were like, I'm not sure what this is. I'm not sure what this is. Oh, wait, the troponin is positive, and the EKG is abnormal. Could this be myopericarditis? And I think the hard part about this case is to really realize that finding the underlying cause for myopericarditis is very difficult. Many people don't have a specific cause. Some people have rare infectious triggers, and some people have deadly autoimmune diseases like giant cell myocarditis and eosinophilic myocarditis. I think to your question, only 70% of patients with eosinophilic myocarditis have peripheral eosinophilia. 30% do not. If you allow me to be transparent about what my thinking is about the biopsy, I'm not an expert in this at all. And I know that there are expert pathologists and cardiologists who analyze this, but I actually am not sure what the patient has. Because I've learned over the years that patients with giant cell myocarditis also have eosinophilic infiltrates. I think if I were to tell you my conclusions based on the report, I think you see multinucleated giant cells and you see eosinophils. That combo makes me think giant cell myocarditis. However, you don't see evidence of necrosis, which is a common feature of giant cell myocarditis. And so I would say, I think this patient either has giant cell myocarditis or eosinophilic myocarditis. I'm not sure. But ultimately, does it matter too much? It probably does long term. I don't know what the recurrence rate is of either of those conditions, but short term, this patient needs steroids now. The way you can distinguish these two, and there are papers and papers and papers written about the challenges distinguishing between the two, but I just want you all to know that even the smartest people in this domain still have a hard time distinguishing eosinophilic from giant cell myocarditis. But I've babbled long enough. I'd love to learn from you, Bharat. How are you guys putting this together? What happened to the patient? What did you learn?
Yeah, absolutely. I mean, you hit the nail on the head. We were kind of stuck between both eosinophilic and giant cell myocarditis and had to recruit some, very smart people to kind of differentiate those two. But exactly as you mentioned, started on IV methylpred in the short term and unfortunately developed some persistent episodes of VT storm, for which we wanted to start him on an IV amio bolus and infusion, but he unfortunately left AMA during that hospitalization. But looking through his chart retrospectively, he finished his prednisone taper, but then 2 months later actually presented in a very similar fashion, diffuse ST elevations, and underwent a second left heart cath, which again was negative. But he declined rapidly during that admission, and unfortunately required, multiple cardioversions, was placed on ECMO, and then he decided to go comfort care. So he's no longer, with us, but um, you know, a lot of learning points, kind of keeping you humble with a very common presentation, but a very prolonged and different kind of outcome from what we initially expected. But kind of three learning points that I had was that we should keep eosinophilic myocarditis on our differential. The gold standard is biopsy, but may not always be, diagnosed if we don't catch that patchy area. And then the treatment for non-infectious eosinophilic myocarditis, as you mentioned, is steroids. So those are kind of the points that I took away from
Yeah,
the
that's
case.
such a tragic outcome. I'm really sorry to hear it, but ultimately goes to show the morbidity of this disease. It's a very, very deadly disease. And I loved having you here. Anytime there's a central midfielder on, you're going to get a little bit of a conduction performance of the presentation. That was, I thought the way you told the story was awesome, and how you painted this picture of a relatively stable appearing person, and then boom, labs and the evolution ultimately until death. It's tragic, but just goes to show you how, to close the loop on the conversation Anmol and I were having, where can you have disease with a lot of reserve? And I think myocarditis is a great example of that, where you need to destroy a large part of the patient's heart for them to ultimately start to feel it. And you can see why he's hurting. He has one heart cell die, one cell heart die, one heart cell die. It hurts, but he needs a sufficient amount of his myocardium to necrose for him to feel shortness of breath ultimately. And so yet a humble reminder of how much your heart can suffer before it really falls off. Absolutely amazing. Any reflections on Mo before we pass the mic to Ashar?
Yes, I just had to, I wanted to add one more thing when we were talking about eosinophilic myocarditis. If we talk about eosinophilic esophagitis as well, I just learned that that even in the patients presenting with GERD, if we biopsy the lower 1/3 of the esophagus, you will see some eosinophils there. But to differentiate it from eosinophilic esophagitis, we biopsy the upper areas. So that is how I think maybe to differentiate, maybe if we don't know about that, we just biopsy the lower third and we'll see eosinophils, we'll say eosinophilic esophagitis, but that can occur in GERD too. And when we were discussing this case, the second point I had, when we saw the chest pain, it just reminded me of a case I saw in clinic. And it was totally the presentation, the symptoms were looking like acute coronary syndrome, but she had subacute chest pain. And upon examination, it was realized that it was a pectoral muscle strain. So it just emphasized the importance of history and physical examination in that case. And but I learned a lot from this case. Thank you so much for bringing up the case, and thank you for giving me the honor of discussing. I really learned a lot.
I couldn't agree more about that. With Anmol, that was awesome. Really, really, really educational case. A lot of bread and butter. How do you think about chest pain? How do you diagnose this? And a lot of esoteria at the end, including Anmol's point to diagnose primary eosinophilic diseases: eosinophilic pneumonia, eosinophilic myocarditis, eosinophilic gastroenteritis, eosinophilic esophagitis. You really need to be dominated by eosinophils with very little other things. Because eosinophils can be an innocent bystander to a diffuse inflammatory process. We see eosinophils in Hodgkin's lymphoma, you see eosinophils in IgG4 disease, but they're not the big picture. And I think that's the tension for me is, are the giant cells the story here? And the eosinophils are the things that are coming there, or are the eosinophils the major picture? So for those of you who are going into cardiology, it's well worth reading about how hard it is to make this diagnosis. For those of you like me who are interested in general medicine, I think you just call this a steroid deficiency state and go from there. But here, why don't we pass the mic to Khashia for the teaching points?
Thank you all for the amazing case and the amazing discussion. I promise I try not to use microscopic fonts, but you guys just do too many teaching points. So let's go through them right now. We started the case with a chest pain that is not our usual case, but we have some don't miss diagnoses that we have to check out in our initial approach, the 4+2+2 framework for cardiac causes, to esophageal causes, and to pulmonary causes. After we check them out in our first pass using our ECG, chest X-rays, and cardiac biomarkers, we have to address the subacuity of our presentation. Usually when a presentation is subacute, it tells us that it's an unusual presentation of something usual, or it's caused by coping mechanisms of the patients, like the patient just took longer to come to the hospital, either because they didn't have access, they didn't want to come, etc., etc. After that, we have to think about high reserves in patients. This is especially concerning in younger patients who have higher reserves. We sometimes see this in shock cases, in precarditis cases, that the initial presentation is subclinical and is concerning regardless because the patient has high reserve. After that, checking out how the pain evolves can tell us about the subacuity. The point of pain is to protect us from dysfunction. So if there is no dysfunction, we have to think about nerves. But if the pain is worsening or the dysfunction is presenting itself, we have to approach from there. After that, we got to risk evaluation of irregular chest pain. Most patients with chest pain have a benign cause, and we use physical examination and rule out tests to identify those with the higher risk first. But if we can't find an immediate cause and we still have suspicion for a sinister cause, we have to look into two specific places that they usually hide themselves: microscopic arteries of the heart and the mediastinum. After discussing the initial presentation of the patient, we got our initial data that had a lot. We have to assemble all of these data pieces like a puzzle. Our initial troponin testing told us that we have muscle damage, which can be caused by Takotsubo, myocarditis, or a missed infarction. A teaching point here was that the troponin stays elevated longer, and if we are checking for reinfarction, we should be using CKMB, which goes down much sooner. After that, we established that we have cardiac damage. We put this data here. We look at our QRS. We have low voltage, which usually tells us that, which usually reminds us of precarditis, but we have to think about the things that cause low voltage. When we see low voltage, there's usually either something in the way of voltage reaching the electrodes, effusion, obesity, COPD, pneumothorax, or the voltage is diseased itself. The muscle is infarcted, there is cellular infiltration, there is inflammation, etc., etc. In the case of precarditis specifically, diffuse ST elevations are seen in all leads except the AVR, which has an ST depression. And another thing here is the low BNP. Unlike what we usually expect, because in precarditis we have external compression of the muscle, not internal stretching of the muscle, we don't usually see a high BNP here. Finally, we saw that we have elevated vascular resistance. Whenever we see this, we have to think that the hypertension is directly from the heart. The patient may be well diuresed, but the output is not getting better. Finally, we arrived at the inflammation. We put all the pieces together and concluded that we have a myocarditis picture. So what is the cause? Usually the cause is idiopathic, which is why we usually don't put patients through the risk of biopsy. But we have to check three main things: drugs and recent vaccinations, infections, and autoimmune. In this case, in which we have an immunocompromised patient, infectious becomes really important. Now we have to ask ourselves, what infections cause myocarditis? We have many infections, especially viral causes, but which ones do it reliably? We have two C's and two T's. The two C's are COVID in post-COVID multisystem inflammatory disease, and Coxsackie virus in hand, foot, mouth disease. And the two T's are Chagas disease and toxoplasmosis, which were of particular concern here. And now we arrive at the final steps: whether we want to do the biopsy and whether we want to give the patients corticosteroids, because there are some highly concerning causes like our patient eosinophilic myocarditis, giant cell myocarditis, that need immediate attention. If we decide to go through biopsy, in which case we decided to do so because the patient had fulminant myocarditis, which developed really fast, it's not recommended to give corticosteroids to increase the efficiency of the biopsy. But if you're not doing it, there are steps you can consider in when you want to give the patient corticosteroids.
Poetry, my friend, poetry. You recounted that entire journey with such precision and clarity, and I love the indentation of the sections as you go along the way. Thank you, Anmol. That was a lot of fun. Thank you, Bharat, for an absolutely incredible case, and a big shout out to Masa for being able to keep up with your case presentation. That was really, really complicated. Really excellent scribing. All right,
Yeah,
thank you all
thank
so
you.
much.
Oh, sorry. I
No,
just
no,
want to
please
say
go
thank
ahead.
you all. Thank you all for having me. It was a great discussion. I just want to thank my team members as well, Dr. Fadden, Dr. Sai Patel, and Dr. Bashir Noor. It helped me a lot with this case. So
Amazing. We really appreciate all the time and effort it took to get here, and hope this is the first of many. Really enjoyed having you here.
thank you all.
Bye.